So this is chapter 14, shock. The national standard competencies for shock and resuscitation applies the fundamental knowledge to provide basic and selected advanced emergency care and transportation based on assessment findings for a patient in shock, respiratory failure or arrest, cardiac failure or arrest, and post-resuscitation management. The pathophysiology applies comprehensive knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. Shock or hypoperfusion describes a state of collapse and failure of the cardiovascular system. In the early stages of shock, body attempts to maintain homeostasis and the balance of all systems in the body. As shock progresses, blood circulation slows and eventually ceases. Shock can occur because of medical or traumatic events. You must be constantly alert to signs and symptoms of shock. Maintain a high index of suspicion. Physiology and perfusion. Perfusion is the circulation of blood within an organ or tissue in adequate amounts. It requires a working cardiovascular system. The body is perfused via the circulatory system. Complex arrangement of connected tubes, which is the arteries, arterioles, capillaries, venules, and veins. There are two circuits, the systemic circulation in the body and the pulmonary circulation in the lungs. Cardiac output, the volume of blood the heart can pump per minute. This depends on myocardial contractility, preload, and afterload. The blood pressure varies directly within cardiac output, the systemic vascular resistance, and blood volume. Cardiac output equals heart rate times stroke volume. Blood pressure equals cardiac output times the systemic vascular resistance. The mean arterial pressure, or MAP, is generally considered the patient's blood pressure. MAP is the diastolic blood pressure plus 1/3 the pulse pressure, which is systolic blood pressure minus diastolic blood pressure. The role of the nervous system is to control the cardiovascular system. What is all that noise?
Madison, she ain't muted.
Madison, mute. Okay. Control of cardiovascular system is a function of the autonomic nervous system. The autonomic nervous system is primarily regulated from the upper part of the medulla oblongata of the brain. Sympathetic nervous system prepares the body for physical activity during a stressful situation. Parasympathetic nervous system is primarily responsible for rest and regeneration. It opposes every action of the sympathetic nervous system. Table 14.1 compares sympathetic and parasympathetic nervous systems. These figures show the sympathetic nervous system on the left and the parasympathetic nervous system on the right, and the effects that both of those cause. Regulation of blood flow. Sphincters regulate blood flow through the capillary beds under the control of the autonomic nervous system. Regulation of blood flow is determined by cellular need and is accomplished by vessel constriction or dilation. Maintenance of blood flow or perfusion is accomplished by the heart, blood vessels, and blood working together. Respiration and oxygenation. For each breath, the alveoli receive a supply of oxygen-rich air. Oxygenated blood passes through the alveolar wall into the fine network of pulmonary capillaries. If oxygenated blood is not properly circulated, cellular death may result. Diffusion is a passive process in which molecules move from an area with a higher concentration of molecules to an area of lower concentration. Oxygen molecules move from the alveoli into the blood. Carbonic acid breaks down in the lungs and carbon dioxide is exhaled. This takes place to maintain the delicate balance between gases and maintain the pH of the body. Pathophysiology. Shock can result from inadequate cardiac output, decreased SVR, or the inability of red blood cells to deliver oxygen to tissues. If a shock state persists, it will ultimately result in death of the entire organism. The body attempts to compensate by shunning blood flow from organs that are more tolerant of low flow, such as the skin and intestines, to vital organs, the heart, brain, lungs, etc. The cardiovascular system consists of three parts: the pump, which is the heart, a set of pipes, which is the blood vessels or arteries that act as the container, and contents of the container, which is the fluid or blood. This figure shows the perfusion triangle. The blood is the vehicle for carrying oxygen and nutrients. It contains red blood cells, white blood cells, platelets, and plasma. Blood clots control blood loss. They form depending on retention of blood because of blockage in blood circulation, blood stasis, changes in the vessel wall, such as a wound, or blood's ability to clot as the result of a disease process or medication. When injury occurs, platelets begin to aggregate at the site of injury. This causes the red blood cells to become sticky and clump together. As red blood cells begin to clump, fibrinogen reinforces the red blood cells, and clots can become unstable and susceptible to rupture. The body's neural and hormonal mechanisms are triggered when body senses that pressure in the system is falling. The sympathetic nervous system will assume more control of the body's functions during a state of shock. Parasympathetic nervous system controls involuntary functions by sending signals to the cardiac, smooth, and glandular muscles and takes over during non-stressful situations. Also, a shifting of body fluids to help maintain pressure within the system. Okay, compensation for decreased perfusion. Baroreceptors sense decreased blood pressure and flow and activate vasomotor center in the medulla oblongata to increase blood pressure. Chemoreceptors measure subtle shifts in amounts of carbon dioxide in the arterial blood. These shifts have an effect on the regulation of the respiratory rate as well as control of the acid-base balance in the body. Stimulation occurs when the systolic pressure is between 60 and 80 millimeters of mercury in adults and even lower in children. In response to hypoperfusion, the renin-angiotensin-aldosterone system in the kidneys is activated and antidiuretic hormone is released from the pituitary gland. The result is an increase in patients' blood pressure and maintenance of cardiac output. The overall response of the initial compensatory mechanism is to increase the preload, stroke volume, and pulse rate, which results in an increase in cardiac output. Autotransfusion effect, along with the subtle effects in other response systems of the body, allows the body to compensate adequately for a volume loss up to 25%. If hypoperfusion persists, myocardial function worsens with decreased cardiac output and ejection fraction. Tissue perfusion decreases. Fluid may leak from the blood vessels, causing systemic and pulmonary edema. As the patient decompensates, perfusion to the brain and coronary arteries decreases. Cells switch from aerobic to anaerobic metabolism. Anaerobic metabolism is the cellular processes occur in the absence of oxygen. Aerobic metabolism is all cell processes occur with an adequate oxygen supply. The body produces epinephrine and norepinephrine in the adrenal glands in response to hypoperfusion. Table 14.2 lists the effects of epinephrine and norepinephrine. Planned shunting of blood from areas of lesser need to areas of greater need is referred to as the pecking order, the golden hour or golden period. Failure of compensatory mechanisms to preserve perfusion result in decreases in preload and cardiac output. Shock-related events at capillary and microcirculatory levels. As perfusion decreases, cellular ischemia occurs. This can quickly result in metabolic acidosis. The body can tolerate anaerobic metabolism for only a limited time. Anaerobic metabolism results in systemic acidosis and depletion of the body's normal high energy reserves. Incomplete glucose breakdown results in an accumulation of pyruvic acid. Ischemia stimulates increased carbon dioxide production by the tissues. Acidosis serves as an indirect measure of tissue perfusion. Reduced levels of ATP result in a dysfunctional sodium-potassium pump. Cellular flooding explodes the lysosomal membrane and releases lysosomal enzymes. Lysosomal enzymes autodigest the cell, leading to organ failure. Reduced blood supply to vasomotor center in the brain results in slowing then stopping of sympathetic nervous system activity. Continuing buildup of lactic acid and carbon dioxide acts as a potent vasodilator. In conjunction with all this injury occurring, white blood cells and blood clotting systems are impaired. Disseminated intravascular coagulation, or DIC, may occur. DIC has also been found to complicate septic shock. Multiple organ dysfunction syndrome, a progressive condition characterized by combined failure of several organs. A major cause of death following septic, traumatic, and burn injuries. Occurs when injury or infection results in the release of numerous inflammatory mediators and activation of a complement system, coagulation system, and kallikrein-Kinin system, maybe. Typically develops within hours to days following resuscitation. Signs and symptoms include hypotension, insufficient tissue perfusion, uncontrollable bleeding, multisystem organ failure caused mainly by hypoxia, tissue acidosis, and severe local alterations of metabolism. Respiratory insufficiency, insufficient concentration of oxygenation in the blood. Let's start that over. Insufficient concentration of oxygen in the blood can produce shock as rapidly as vascular causes. Without oxygen, organs in the body cannot survive. Certain types of poisoning may affect the ability of cells to metabolize or carry oxygen. Carbon monoxide poisoning and cyanide poisoning are examples. Anemia is defined as an abnormally low number of red blood cells. It may be the result of either chronic or acute bleeding. If severe anemia is present, tissues may be hypoxic. Causes of shock. Shock can result from many conditions, including bleeding, respiratory failure, acute allergic reactions, or overwhelming infection. Expect shock if a patient has multiple severe fractures, abdominal or chest injury, spinal injury, severe infection, major heart attack, or anaphylaxis. Types of shock. Shock may be the result of a variety of causes. Hypovolemia from blood or fluid loss is a common culprit. Table 14.4 explains the differences between the types of non-hypovolemic shock and how to differentiate them from hypovolemic shock. Hypovolemic shock is shock due to inadequate blood volume. Hemorrhagic and non-hemorrhagic causes of hypovolemic shock. See Chapter 27, Bleeding, for information on treatment of hemorrhagic shock. Non-hemorrhagic shock occurs when the fluid loss is contained within the body. Abnormal losses of fluids and electrolytes or dehydration may occur through gastrointestinal losses, especially through vomiting and diarrhea. Increased loss as a result of fever, hyperventilation, or high environmental temperatures through the lungs. Increased and excessive sweating. Internal losses as in peritonitis, pancreatitis, and ileus. Plasma losses from burns, drains, and granulating wounds. Other causes include ascites, diabetes, insipidus, and osmotic diuresis, secondary to hyperosmolar states. The earliest signs of shock are relentless and restlessness. Earliest signs of shock are restlessness and anxiety. If conscious, the patient may report being thirsty, skin becomes pale, cold, and clammy, and the heart speeds up. Symptoms of dehydration include loss of appetite, nausea, vomiting, and sometimes fainting. As bleeding or fluid loss continues, the blood pressure finally falls in the shock patient. Do not wait until the blood pressure falls before you suspect shock and begin treatment. Table 14.5 summarizes the signs and symptoms of hypovolemic shock. The goal in treating shock is to save the brain, lungs, and kidneys. Cardiogenic shock is caused by inadequate function of the heart or pump failure. Edema is the presence of abnormally large amounts of fluid between cells and body tissues. Pulmonary edema results in impaired ventilation. For blood to circulate efficiently, there must be the right amount of pressure and an adequate number of heartbeats. Cardiogenic shock develops when the heart cannot maintain sufficient output to meet the demands of the body. As afterload increases, cardiac output decreases. This may result from low cardiac output due to high afterload, low preload, poor contractility, or any combination of the three. Obstructive shock results when conditions that cause mechanical obstruction of the cardiac muscle also affect pump function. Cardiac tamponade occurs when blood leaks into the pericardium. It is caused by blunt or penetrating trauma and can progress rapidly. Tension pneumothorax caused by damage to the lung tissue. The heart and respiratory rates increase and become shallower, and blood pressure decreases. Pulmonary embolism is a blood clot that occurs in the pulmonary circulation. It can prevent blood from being pumped from the right side of the heart to the left. Distributive shock results when there is widespread dilation of the small arterioles, small venules, or both. Septic shock occurs as a result of severe infections, usually bacterial. Toxins damage the vessel walls, causing increased cellular permeability. Presents similarly to hemorrhagic shock. You have a weak, thready pulse, shallow, rapid respirations, altered mental status, and warm or hot skin. Neurogenic shock results due to damage to the nervous system that controls the size and muscular tone of the blood vessels. Muscles in the walls of the blood vessels are cut off from the sympathetic nervous system, and nerve impulses that cause them to contract. All vessels below the level of the spinal injury dilate widely, increasing the size and capacity of the vascular system. Characteristic signs are absence of sweating below the level of the injury, normal warm skin, and lack of an elevated pulse.
Stacey, you are majorly a robot, or is that just?
Can you hear me now?
Yeah, you sound like a robot. Yeah.
Is this better?
No.
No.
You still sound like a robot.
Hang on. We're almost done. Alright, anaphylactic shock occurs when a person reacts violently to a substance to which he or she has been sensitized. Sensitization is becoming sensitive to a substance that did not initially cause a reaction. There is no loss of blood, no mechanical vascular damage, and only a slight possibility of direct cardiac muscular injury. It results in widespread vascular dilation, increased permeability, and bronchoconstriction. Instances that cause severe allergic reactions are injections, stings, ingestion, and inhalation. It can develop within minutes or even seconds after contact with a substance to which the patient is allergic. Cyanosis is a late sign of anaphylactic shock. Oh, they didn't give us any notes about that one. So, psychogenic shock occurs when a patient has had a sudden reaction of the nervous system that produces temporary generalized vascular dilation, resulting in fainting. The progression of shock. Shock occurs in two successive stages, compensated and decompensated. Compensated shock is the early stage of shock while the body can still compensate for blood loss. Decompensated shock is the late stage when blood pressure is falling. Irreversible shock is shock that has progressed to a terminal stage. Table 14.6 summarizes the progression of shock in your book. Compensated shock. At this stage, the level of responsiveness is a better indicator of tissue perfusion than most other vital signs. Chemical mediators are released by the autonomic nervous system, increasing the rate and depth of respirations. Blood pressure is maintained. There is a narrowing of the pulse pressure. The pulse pressure equals the systolic pressure minus the diastolic pressure. Patients may have positive orthostatic vital signs, and treatment at this stage will typically result in recovery. Decompensated shock, blood pressure falls, blood volume decreases more than 30%. Compensatory mechanisms begin to fail, and signs and symptoms are much more obvious. Cardiac output falls dramatically. Vasoconstriction can have a disastrous effect if allowed to continue. Treatment at this stage will sometimes result in recovery. Irreversible shock, arterial blood pressure is abnormally low. A rapid deterioration of the cardiovascular system occurs that cannot be reversed. Life-threatening reductions in cardiac output, blood pressure, and tissue perfusion occur. Distinction between decompensated shock and irreversible shock is made based on the failure of the shock state to reverse with appropriate treatment. It's not possible to distinguish irreversible shock from severe decompensated shock in the pre-hospital environment. In patient assessment, scene size up, be alert to potential hazards to your safety. Once on scene, look for and address hazards and threats to the safety of the crew, bystanders, and patient. Put several pairs of gloves in your pocket for easy access. Observe the scene and patient for clues to determine the nature of the illness or the mechanism of injury. The more traumatic injuries a patient has sustained, the less likely the patient will be able to compensate. Primary survey, perform a rapid full body scan of the patient to determine LOC, identify and manage life-threatening concerns, determine priority of patient and transport, treat circulation, airway, or breathing. Threats to circulation, airway, or breathing are considered life-threatening and must be treated immediately. Life-threatening bleeding should be treated first. Quickly assess the patient's breathing. Observe the patient for signs of accessory muscles. Increased respiratory rate is often an early sign of impending shock. Assess the patient's circulatory status. Check for the presence of a distal pulse. A rapid pulse suggests compensated shock. Maintain a high index of suspicion for occult injuries. If the patient shows signs of hypoperfusion, gain IV access, treat aggressively, and provide rapid transport. Administer fluid en route. Do not delay transport to complete non-life-saving treatments. Instead, perform these treatments en route. History taking. Determine the chief complaint. Obtain a medical history and be alert for injury-specific signs and symptoms. Quickly obtain a sample history from the patient. If the patient experiences a substantial change in LOC before arrival at the hospital, provide the hospital personnel with this important information. Blood thinners can make bleeding injuries considerably worse. Secondary assessment, repeat the primary survey to identify injuries not yet found. Start with a full body exam to be sure that you have identified all injuries. Treat life-threatening problems immediately. Obtain a complete set of baseline vital signs. If the patient's condition is unstable, reassess vital signs every 5 minutes. If the patient is in stable condition, reassess vital signs every 10 to 15 minutes. Use monitoring devices to quantify the patient's oxygenation and circulatory status. Use a pulse oximeter to evaluate the effectiveness of oxygenation. Use a manual technique to monitor blood pressure first before using a non-invasive blood pressure monitor. Use a glucometer to monitor blood glucose levels. Reassessment, the rule of thumb is assess, intervene, reassess. Determine if the interventions performed are having any effect on the patient. Determine the interventions needed for your patient at this point based on the findings. Focus on supporting the cardiovascular system. Treating for shock early and aggressively will help to prevent inadequate perfusion from harming your patient. Patients who are in decompensated shock will need rapid interventions to restore adequate perfusion. Emergency medical care for shock. Treatment for shock will begin during the assessment process. Control all obvious external bleeding. Place dry, sterile bandages over the bleeding sites, securing with bandages. Apply a tourniquet. Place patient in position dictated by local protocol for shock patients. Provide warmth, gain IV access, and administer fluid. To prevent the loss of body heat, place blankets under and over the patient. Be careful not to warm the body too much. Transport the patient and treat additional problems en route. The golden hour refers to the first 60 minutes after injury. To relieve the intense thirst that often accompanies shock, give the patient a moistened piece of gauze to chew or suck. Initial management for shock: manage the airway, administer supplemental oxygen, place the patient in a position of comfort, obtain vital signs, obtain IV or IO access for medication or fluid bolus, and maintain body heat. Table 14.8 lists the general supportive measures for the major types of shock. IV therapy. IV lines are inserted to provide a route for immediate replacement of fluid in patients, a route for potential replacement in patients who are at risk of losing substantial volumes of fluid or blood, and a route for the administration of medication. All patients in hypovolemic shock need IV fluid replacement. In case of need for emergency administration of medications, IV lines should also be inserted TKO. TKO means to keep open. Most protocols advise administration of IV fluid in boluses of 20 milliliters per kilogram up to 30 milliliters per kilogram in 250 to 500 milliliter increments until radial pulses return. If vital signs return to within normal limits, slow IV fluid administration to a TKO rate and reassess frequently. Call early for paramedic intervention to administer vasopressors if needed. Special considerations in fluid resuscitation. For instances where increasing blood pressure may be detrimental to the patient, it is necessary to administer only enough fluid to maintain radial pulses. Aggressive fluid therapy increases the workload on the heart, worsening cardiogenic shock and increasing internal bleeding. Temperature control is vital to maintaining perfusion in children and infants. Use a Braslow tape or other reference to remember normal vital signs by age. Carefully monitor the patient's status and treat conservatively in instances of uncontrolled hemorrhage. Patients who have chronic hypertension may require a higher blood pressure to achieve the same level of end organ perfusion. Only way to maintain fetal perfusion is to aggressively treat the woman. Place pregnant patients in a left lateral recumbent position. Assessment and management of specific types of shock. Treating hypovolemic shock. Control all obvious external bleeding en route to the ED. Establish at least one 18 gauge or larger peripheral IV line. Recognize internal bleeding and provide aggressive general support. Secure and maintain an airway and provide respiratory support. Do not give the patient anything by mouth. Monitor the patient's mental status, pulse rate, blood pressure. Provide rapid transport to the closest, most appropriate facility. Cardiogenic shock. A patient cardiogenic shock as a result of a heart attack does not need excess fluid. Chronic lung disease will aggravate cardiogenic shock. Before administering nitroglycerin, be sure systolic blood pressure is greater than 90 and consult with medical control. Assess the patient's blood pressure and gain IV access prior to nitroglycerin administration. Place patient in the position of comfort and administer high-flow oxygen. Provide prompt transport to the ED. Gain IV access and administer fluid at a TKO rate. Frequently check for a pulse in an unresponsive patient to identify whether an automated external defibrillator is needed. So why do you want a blood pressure higher than 90 before you give nitroglycerin?
And
Do what?
can you hear me? Can
No,
you hear me?
no, you sound correct.
Hello?
Now,
Can you hear me now?
that's better.
It makes your blood pressure drop.
That is correct. It makes your blood
Hey,
pressure
y'all.
drop. Good job.
Now can you hear me?
Yes,
Can you? Okay.
you're absolutely right. It makes your blood pressure drop. So you want to make sure that the blood pressure is above 90.
Maddie just left me hanging.
I know.
Maddie didn't even help me. She just left me hanging.
So,
I'm sorry. I knew that you could do it. I was giving you a chance to pull through. I hear you.
So you want to make sure the blood pressure is higher than 90, and you want to make sure you got IV access so that if it drops too low, you can give a fluid bolus to bring that blood pressure back up. All right, treating obstructive shock, cardiac tamponade. Increasing cardiac output should be the priority. Apply high flow oxygen. Weigh the need for positive pressure ventilations against the possibility of hypoventilation. The only definitive treatment is surgery or pericardiocentesis. The only treatment available to pre-hospital providers is early recognition and rapid transport for definitive care. Attention pneumothorax, high-flow oxygen via non-rebreathing mask should be applied early to prevent hypoxia. Provide decompression of injured side of chest using needle chest decompression. Gain IV access as a medication route and administer fluid at a TKO rate. A pulmonary embolus, assess blood pressure, provide a fluid bolus of 250 milliliters of crystalloid solution, and recheck blood pressure. The patient may breathe more comfortably in an upright or partially upright position. Definitive treatment involves anticoagulation to prevent progression, ventilatory and circulatory support, and occasionally thrombolytic therapy or clot retrieval. This is not possible in the pre-hospital setting, so rapid transport to an appropriate facility is indicated. Treating septic shock requires complex hospital management, including antibiotics. Use appropriate standard precautions and transport as promptly as possible. Use high-flow oxygen during transport and gain IV access en route and administer fluid boluses to maintain radial pulses. Treating neurogenic shock. This is best treated by a combination of all non-supportive measures. Emergency treatment must be directed at obtaining and maintaining a proper airway, providing spinal immobilization, assisting in adequate breathing as needed, conserving body heat, and providing the most effective circulation possible. Transport promptly. And anaphylactic shock. Administer epinephrine by way of subcutaneous or intramuscular injection. A patient who is aware of having a specific sensitivity may carry a bee-sting kit containing epinephrine. If patient signs and symptoms recur or patient's condition deteriorates, repeat the injection after consulting with medical control. Promptly transport the patient to the ED while providing all possible support. Try to determine what agent caused the reaction and how it was received. Keep in mind that a mild reaction may worsen. Gain IV access as a medication route and administer fluid at a TKO rate. Psychogenic shock. Psychogenic shock can substantially worsen other types of shock. Record your initial observations of vital signs in LOC. Try to learn from bystanders whether the patient reported any problems before fainting and how long he or she was unresponsive. Treating respiratory insufficiency. Immediately seal any hole in the chest, stabilize impaled objects in the chest, secure and maintain the airway, and administer supplemental oxygen. Clear the mouth and throat of any obstructions. Determine the need to assist ventilations with a bag mask device and supplemental oxygen. Determine the most appropriate transportation destination based on the patient's condition and local